So yeah, I now go to bed.
Oh,
Great. Right. And then the little like loopy loop things that aren't even like
I don't even know if it does.
you can tell them to walk away from the front though how well they got it.
Isn't that fun? Him on
No, I got it last night. Right, of course. You know what though? What I got from there.
finish up.
Or you can that's the broken heart one, right? Which is
Okay, good morning. We're going to do a little review of what we talked about last time we were here. I guess it was Friday, huh? Wow, you still like me. So one of my former students had this cool little app. I don't know if it's still free, so if you have an iPad or iPhone or iPod Touch, this company called Heart Decide has various apps, and they are so amazing. And I'm not a morning person, but I play with this all day Saturday morning, so it must be really cool.
what's it called?
Heart Decide. This is Heart Decide. They have ENT Decide. It just takes anatomy and physiology, make it 3D, where you can play with it and all different kind of stuff. So I downloaded a few of these apps, and today we're just gonna kind of play with it and review what we talked about last week. So I get, this is the heart. So we're not talking about that part, right? But let's look at the different layers of the heart. So this layer has the fat on it. Take that away and just go to the veins. We can do something pretty cool, and it will show us all the veins. So turn it around. So you see your pulmonary artery. You see your pulmonary veins, your circumflex artery. So this is what the heart looks like, okay? And all these things that we're talking about, and the different arteries and atherosclerosis and veins, that's what it actually looks like. You can even go down to the muscle. Take that view away. And you see the pulmonary trunk. Here's your aorta. You have your aortic arch. Your superior vena cava. Your inferior vena cava. Your pulmonary trunk. Don't know what an oral port is. Size off of that Neo, what was that? The Matrix. But apparently the heart has an oral port. So we talked about coronary artery disease, correct? We talked about atherosclerosis. We talked about heart failure. So instead of me boring you, let's let heart decide.
A cardiac catheterization allows doctors to see the inside of your heart without doing surgery to open your chest. Pretty amazing. The arteries in your groin or your arm carry blood from the heart. That means they also are like a highway leading back to your heart. First, the skin is numbed. Then the doctor places a needle into the artery and runs a guide wire through the needle. The needle is removed, and then a small plastic tube called a catheter is pushed into the artery. Now the doctor carefully guides the catheter up the body's main artery towards the heart. See that circle? In the middle of the circle is the tip of the catheter. The tip of the catheter moves up the main artery to the heart and the coronary arteries. From there, the doctor can take pictures of the coronary arteries, measure pressure inside the four chambers of the heart, or perform procedures like angioplasty and stent placement. We have common questions and answers about cardiac catheterization in the conditions section. An angioplasty and stent placement opens blocked arteries. The procedure requires a cardiac catheterization. Now we're inside a heart artery. Here's the plaque that's blocking the flow of blood, and here comes the catheter. It has a balloon at its tip. Wrapped around the balloon is a tiny wire mesh cylinder called a stent. Once the balloon is in place, the doctor inflates it. As the balloon expands, the stent around it expands too. Together, the balloon and stent squash the plaque against the walls of the artery, making more room for the blood to flow. Then the balloon is deflated. But notice, the stent remains expanded. It's still holding the artery open. The catheter and balloon are pulled out of the artery and out of the body, but the stent remains in place inside the artery, keeping it open. Angioplasty and stent placement almost always give immediate relief from chest pain of a heart attack. We have common questions and answers about angioplasty and stenting in the conditions section.
So does that kind of make it a little more tangible or palatable, talking about it, and now that you see it, this is what your patient goes through. And so those nursing interventions we talked about, why they have to lie flat, why you have to assess your pulses bilaterally, why your CMS, your circulation, motion, and sensation is so important.
So the plaque can't be removed completely?
Depending upon how much is clogging. Sometimes they have to go on your roto-rooter, literally, and clean all that stuff out. And then when they can't get out, they'll put a stent in there. Stents now are medicated, so they last longer, so they're coated with something. And hopefully 5 years they won't be used again, but sometimes they do. Yeah.
We got to go to the April, Jamie and I got to go to the cath lab yesterday and see an angiogram, and they were telling us that like with the plaque, that's usually not like here's the artery and here's the plaque, but the plaque is inside the artery wall, and it's not like they can go in there and take it out. They have to just, they said it was like a controlled dissection of the artery. They just have to keep the stent there, keeping it open, because that artery is like, it's very stiff. It's, you know, it's yeah, so they can't always go in and take it out. It's gotta be, you know.
If I can get the audio to work with this, it kind of
Atherosclerosis is a disease in which cholesterol builds up in the walls of arteries. Arteries are flexible tubes that carry oxygen-rich blood to all of your body. Every artery has a wall, an inner lining, and an open space in the middle. The heart pumps blood through the artery like water flowing through a pipe. Cholesterol, a kind of fat, travels in the blood. See the yellow specks in the blood? Those are little particles of fat. Atherosclerosis begins when something injures the inner lining of the artery, like high blood pressure or smoking. Cholesterol starts to burrow under the artery's inner lining, causing what are called fatty streaks. In people who eat fatty diets, fatty streaks may form as early as age 20. The cholesterol causes inflammation, and the cholesterol-filled plaque develops. Now see this? This is a fibrous cap that grows over the top of the plaque. The cap holds the cholesterol inside the plaque. So far, this plaque hasn't affected the flow of blood through the artery, but over time, the plaque can continue to grow. It invades the space in the middle of the artery and slows the flow of blood. When atherosclerosis affects the arteries of the heart, it can cause chest pain called angina and a heart attack. Take a look at the animations and information about angina and about heart attack, and the common questions and answers about atherosclerosis in the conditions section.
So, does that coincide with what you learned yesterday?
First of all, like, you know, when they change their diet, or is it already too late? You just have to prevent further.
You have to prevent further, because the
There's no
injury is
reverse.
already there, the damage is already done, but that does not mean you can make necessary changes to keep it from progressing.
Correct. Okay.
Alright, so basically, when we get to, angina, did that,
In anatomy,
the little activity that we did in class, did that really help you guys understand preload, afterload, right-sided failure, and left-sided failure? So you can kind of get a visual of what's really going on in the body. Okay, so remember that visual, and now this is going to take you just a little bit further with the 3D animation of the real body.
saw how the heart is supposed to work. Heart failure occurs when either the left or right side of the heart doesn't work properly. When the left side of the heart isn't working like it should, blood gets backed up in the lungs. This makes you short of breath. Also, not enough oxygen-rich blood is getting to the body. This causes fatigue. Because the kidneys are getting too little blood, they don't make enough urine, so fluid builds up in the body. This can cause swelling of the tissues, most easily recognized in the lower legs and feet. When the right side of the heart isn't working like it should, blood returning from the body backs up in tissues throughout the body. This too causes swelling in the lower legs and feet. The sluggish flow of blood in heart failure also can lead to blood clots forming in the heart. They can travel to the brain and cause a stroke. Blood clots can also form in the legs and then travel to the lungs, a potentially serious condition. Finally, the failing heart can develop dangerous heart rhythms that can cause sudden death. We have common questions and answers about heart failure in the conditions section.
Alright, is this helpful to you guys?
What is that called?
Heart
Heart
decide.
decide. You have heart decide, I decide, ENT decide, man decide. You just decide what you want to decide. Alright, so now we kind of went back a little bit and we talked about the heart failure. We talked about atherosclerosis. We actually got to see what it looks like in a vein. Coronary artery disease. We talked about modifiable, non-modifiable risk factors, all of those things. And we kind of stopped here with medications. So we kind of gave you a little tidbit about how to study pharmacology. Just pick one, the one that you know you see the most. Learn that inside and out. There's always something quirky about other medications in that class. And learn that quirk, and you pretty much have the whole class of medications. They do the same thing, but they may work a little differently. Hopefully you found in your book the tables that I was speaking of with all the different medications, their actions, and side effects. So we left off here with the statins, and this is your cholesterol. It blocks cholesterol synthesis. It's gonna lower your LDL, which is which one, good or bad? Bad. Your LDL is bad. Think of low. Think of how you feel after you eat a nice fattening meal, okay? And triglyceride levels and HDL. Okay, that's the good one. When you eat healthy, you're light, you're happy, you're high. You can do, not high like physically high, but high as in you have energy and you can go and do things. Side effects: increased liver enzymes. How will you know that your patient has increased liver enzymes? By looking at them. Jaundice. Okay. Asking them questions. What might they say to you? Okay. What else might they say? What are those side effects up there? Muscle cramps. What is myalgia? Aches. Okay. So general aches and pains probably in the muscle. What labs could you anticipate the physician to order? What did you say? Okay, cardiac enzymes in relation to this medication. What? A CMP. What's in that CMP? Okay, BUN and creatinine. Why is that important? Your kidneys. What's so special about our kidneys? They filter. Now let's connect the dots here. We're talking about a medication that works in the liver. Why is our kidneys important to the medication that works in the liver? Oh, really? It excretes it. It excretes it. Okay, so if this remember we talked about first pass medication. What does that mean?
Synthesized liver.
Synthesized by the liver. Where does this medication work? In the liver. Where is it going to be metabolized? Once it is broken down and the metabolites are going through the body, where does that go to? The kidney. See the connectedness there? Okay. So any medication, you want to check your BUN and creatinine levels because where does it have to go through the body? It has to get out, right? It goes out through the kidneys. Wake up. What are some teaching things you would teach your patient about taking a statin?
Don't drink wine.
Don't drink what? And is that realistic? You said something very key. You said for what? For some. So, this block, we want you to think of things that are realistic. And they're only realistic based on what? The person. So, everything has to be individualized. So, you had to learn all of those things last semester, right? They are valid. Now, we're going to take them and make them patient-specific, cultural-specific, population-specific, socioeconomically specific, okay? So these are the things we want you guys to think about. So if you know your patient has hypertension, they have diabetes, they take this, and we also know they have a little activity that they like to do, which is a little more excessive than someone else. Would that stop you from telling them they need to control their alcohol intake while on this medication? So how would you tell them that? Reduce. Come talk it out. You said reduce. What does reduce mean?
So see what they comfortably drink in a day and cut it in half at least.
That's it. Right there. Can you change them? No. And this is actually a theory of somebody. I can't even remember what the theory is. But I thought it was bartering and trading. But actually, it is a theory. It is a patient teaching theory where you meet the patient where they are. You give them attainable goals to get the outcome that we want. So you drink 5 drinks a day. Can we cut it down to 4 for the first so many weeks? By the time you come back for your 3rd month checkup, can you see if we can get you down to maybe 3 drinks a day? Is that attainable for somebody who's been drinking 5 to 6 drinks? Or God knows how long? So baby steps, right? All right, nicotinic acid. Did somebody turn these how enough good job. Alright. This is niacin. Your B vitamin, right? There's a little misnomer about those statins. All the stuff can be done naturalistically, right? Can't you just go buy some niacin tablets and take 6 of them so many times a day? So why are we giving our patients all of these medications for all of these horrific side effects if we can do it natural and holistic?
It's not regulated.
By who?
Vitamins are
FDA.
regulated.
Isn't that a vitamin?
Yeah, but you don't know.
Maybe
how
different
it's
people
gonna-
react.
Vitamins are cheap and statins are expensive.
Thank you. That's it right there. I'm a cardiologist. I make friends with Rob. Rob is my drug rep. I push that medication.
You would
Rob
deal
kind
with
of
Rob.
put some, little funds into my practice. That's failing a little bit, because we have all these healthcare reform things and issues and stuff going on. So, once a physician that I work with found out that simvastatin is just this, he stopped prescribing it and started telling his patients to use this. And at first I was like, oh, you want to get it? But then it made sense. His patients could afford this versus going through jumping hoops and hurdles trying to get it approved by the insurance company. Now remember, when medications first come out, they have to be tried, true, and proven before insurance companies will foot the bill for them. So if I know they can go to Whole Foods or Sprouts and get vitamin B6 and I can put them on the path of getting that cholesterol down, then that's what I'm going to do. More and more people are educated now, am I correct? Everybody's on what kind of health craze now? Naturopathic, they're on the web, they're on everywhere. Mr. Google knows everything. There's an app for everything, right? So you have to be just as versed in what everybody else has access to, and you have to be able to educate and advocate for your patient. How can we marry the two, okay? You just can't expect them, because some people do that. The doctor gives them the pill, they run, they go take it, and they can't figure out why they have an extra head in the morning. Some people won't do it. We are like the middleman. We have to make it work. Yes.
I've heard that like omega-3 fatty acids, and maybe this is the same idea. It increases your HDL and lowers your LDL. But how does that work? Like, how does it?
I can't even explain that to you. I don't
But
know.
it's the same. Is it the same
It's like it's the
idea
same
as
principle.
like the?
So how did people survive before we had all this stuff? They ate better. They were more active. McDonald's wasn't on every third corner, right? So these are the same. This is a vitamin B. So same side effects as your statins, right? So remember those. And the little quirky stuff. Here we go. Some GI upset. Abdominal pain, nausea, vomiting, diarrhea. Any medication, if you get that on the test, that's one of the things. Take it. Gout. What is gout?
The toe thing.
It's the toe thing.
Deposits in your
Uric acid. Where is the uric acid thing from? The kidneys. All right. You were talking about the heart. We've gone to the toe. Now we're talking back up with the kidneys. Everything is interconnected. You can't separate one from the other. What is flushing?
hot.
Hot. Who knows about hot? We flush. Right. All right. But the function of this one is our lipoprotein synthesis is decreased, our LDL and our triglycerides are decreased. What's missing from this that was on the other slide?
HDL.
HDL. All right. So now you know about 2 medications, right? Nitrates. This is going to be your nitroglycerin. Those are your roots. This is the function. So remember that little thing we did with preload and afterload. Dilate coronary arteries. What is dilating the arteries going to do? Open them up. When it's something that's been closed and tight, our blood pressure goes where? Up. Because we have what's in there? Resistance, right? So the heart is working what? Harder. So our workload is increased. Our cardiac output is decreased. All right? So your patient is going to look like what? Tired. Somebody say mad.
Hypertensive.
Hypertensive. What are they going to be complaining of?
Shortness.
Chest pain, shortness of breath,
Headache.
a headache. How might they look?
Flush.
Flushed. What else? Diaphoretic, sweaty. All right, this is how we want you guys to think, just like this. Now, before you give somebody some nitro, I'm going to need you to do a couple of things. One, what little vital sign would you like to know? Very good. Blood pressure. Okay, so let's take that blood pressure. We know that if it's high, we're going to give them some nitro. We can give 3 nitroglycerin tablets. We call them 3-stat nitros. You give 1 tablet every 5 minutes. So in 15 minutes, you have a total of what? 3. Every time you give that, you want to check your what? Blood pressure. Okay. Where else do we have arteries? Everywhere. Oh, that was not a trick question. Everywhere. So, now let's think about this. My heart is working hard. It is ischemic. Oxygen is not getting everywhere. You told me that I'm going to be diaphoretic. I may have a headache. How else do you know I'm not perfusing up here? What did you say? Huh? Confusion. And another one starts with an A.
Anxiety.
Anxiousness. Okay, so I know that. Now, I give them a nitro tablet under the tongue. What is your expectation? How do you know that that nitro is starting to work? Okay, so what's the first thing we hope that will go away? Chest pain. All right. Even before you start doing the monitor, you have to look at your patient and figure out if what you're doing is working. So they're going to say their chest pain is either gone or decreased. If they were sweaty and anxious, what should happen? Start to calm down, okay, and relax. Now, I wasn't getting perfusion somewhere. Now I'm starting to perfuse up here. Get oxygen, what might they complain of up there? A headache. Is that a common side effect? Yes. So is that an expected side effect? Yes. So that lets us know in this case what we are doing is working. Okay? So you check that again. Our hope is that their pain goes to 0. Anyone who gets relief from nitro won themselves a hospital stay. Because that lets us know that that heart somewhere is not able to perfuse because something is blocking it from doing so. So it's going to decrease our preload and afterload. Why? Everything's open up, so we have a clear path, right? So everybody can move through where they need to be. Your side effects, right there. Headache, lower blood. Why do we become tachycardic? Compensation. She said it perfectly. Your blood pressure goes down, right? Your heart rate is going to go up to compensate. You have to meet in the middle, correct? Usually, if in the emergency department, we'll do the 3 sublingual. Sometimes, depending on what those cardiac enzymes, those cardiac markers were, what's in that panel? Your troponin, your CK, your CKMB, and it was one more, I think. Your myoglobin. Okay. We know that you are having a heart attack if your troponin increases. Okay, that's your marker. Your troponin 1. They have several other different ones, but usually we're looking at troponin 1. If that goes up, then we know that you're actively having a heart attack. They may start you on a nitro drip, okay? Nothing changes. You still need to check those blood pressures. You might want to check them a little more often than every 5 minutes, because now, what do you know about medications that are given intravenously? They work faster, right? And you can't call it back, okay? What is buccal? Where does that go? Okay. Talk about sublingual. I forgot to put one up there. How else can you give it? Transdermal. You can do the patch or you can do the paste. If you are putting on a nitro patch, make sure you find the ones that are still on there. You go give your morning meds and your patient's blood pressure is 90/40, don't call a code. Yes. Flip them over and see how many nitro patches you can find to take off of them. I'm serious. Yeah, the little old lady, she had 3 nitro patches on. Oh, I'm trying to kill her. That's not nice. So we found it. We took them off. Do you think we put the new nitro patch on? No. She was like, I feel so much better. We were like, thanks. Like, yeah. We didn't tell her she had 3 patches still on her. So that's communication. If I'm coming off, I'm telling you, okay, look, I put her nitro patch on. This is where I put it. So back in the day when you paper charted, you said nitro patch, right upper chest or whatever. You had to initial it and put the date and time on it. Well, now here comes computers and people think that people still don't exist. You're taking over from me. It might be nice if you go in and check and make sure that it's there. Sometimes they're supposed to take them off at night. So depending on what the order is, it's on in the morning and off at night. But if that is not your order and you're coming on the next day, please check and make sure you take that patch off before you put the next one on. PO. Some people take nitrates every day, all the time. Mdor is a medication that they can take to control their blood pressure. Any questions about nitro? The main thing you need to put away from this is how it works, okay? Your side effects, and how do you know that this is working in your patient?
Professor Bethune.
Yes, ma'am.
I know you guys are just into pharmacology, but there is a med that you better make sure if it's a male, that person is not regularly taking at least that day. Oh, you gonna get to that? Okay.
She said can't wait. That's it. We're gonna talk about that when we get to your minds. Beta blockers. I like to color code stuff because I'm a very visual person. Why do you think that's color coded?
Same. That's how you remember.
Yes, that's how you remember. Your beta blockers end in OL. Toprolol, low-pressor toprol, atenolol, tenormin. You speak several different languages. You speak pharmacologies. Within that, you have 2 languages. You have generic and you have trade name. You need to be versed in both. Depending upon what your patient's insurance company may cover, they may cover only generic, but you may need to know the trade name, okay? This is given IV and PO. This is the function. Where else do you have beta cells? Where? In the lungs. Oh, look at the side effect down there. So this one works on the beta cells, hence the term beta blocker, okay? It is, what does sympathetic mean? Fight or flight. You have your sympathetic and your parasympathetic, right? Which one is the flight?
Sympathetic.
All right. So this one is going to decrease our heart rate, decrease our blood pressure, and decrease the contractility, the workload. What does this sound similar to? What did you say? Nitrates. Does this not sound similar to nitrates, okay? So even though you have different classes of medications, they can do the same thing, but their mechanism of action may be different. This one specifically works on beta blockers. Our nitrates specifically work on what? All right, the coronary arteries. Our side effects here, no brainer. Anything that's going to decrease contractility, decrease our blood pressure, those are going to be our side effects, right? But look at this one. You're going to have decreased blood pressure and bradycardia, as with nitrates, you had decreased blood pressure and what? All right.
Why?
I'm going to tell you.
Because this works on the beta blockers and we are decreasing our contractility, it is to slow everything down. Okay? So remember, with our workload, if we're making the heart work, we're pumping. It's going to work faster, right? It's going to increase our blood pressure. We need to decrease that workload, slow it down. By decreasing our workload and slowing it down, decreasing that blood pressure, what is the hope the body will be able to do? Return to normal how? What do we need to get all over the body? Oxygen, okay? This is to increase our perfusion. If you slow things, just think about your regular life. You're running, you're helter-skelter, you're all over the place, you really don't know what's going on, but when you take a step back, slow down, and exhale, can you not think more clearly? Can you not accomplish more things? This is the same thing that the beta blocker does for the heart. It slows things down, lets the heart work as it should, not under duress, increases perfusion, but it's still going to lower our blood pressure. All these medications that we talked about, they all have very similar side effects. What condition can you think of that these persons will be predisposed to? That is correct. Orthostatic hypotension. So even though all these medications come from different classes, one condition is the same. What teaching would you like to do to these patients? Rise slowly. What happens as we get older? Fall risk. I heard somebody say they have to go to the bathroom more. So these people are probably taking other medications that can increase the potential of orthostatic hypotension. Like what? A diuretic. So this person is bradycardic. Their blood pressure is low. We're giving them a diuretic. The diuretic does what? Decreases the blood pressure, takes fluid off, okay? Makes you a little dizzy. What if you were the home health nurse and you were going in to an elderly person's home, what might you find? Not yet. That's going to be your job. What do you find? Throw rugs. What else?
Just knickknacks everywhere.
Knickknacks everywhere. They have stuff from when they were 2 years old, okay? So you have to go in there and you're gonna do a safety check, right? So what would you like for that house to look like? You want it to look like this? Well lit. What else would you like to do? Uncluttered, clear paths. What else? Amy, you're on.
That's all right.
I said you're on. What did you want to give them?
Oh, bedside mode.
Yeah. She's like, I don't know. Why give them a bedside commode? Said, okay, they can't move that fast, right? And if you take a diuretic and you're taking all this and you have to get up at 3 o'clock in the morning, I'm not that old, but sometimes at 3 in the morning I'm stumbling and sitting and got my eyes closed. So I can only imagine taking all these meds trying to get up and make it to the bathroom. So maybe a bedside commode is not a bad idea. Okay, I heard arm rails and all those kind of things, handrails in the bathroom, whatever you need to do to make them autonomous, safe, and to keep their independence and their dignity. Now, yes, ma'am.
Why would you give, and maybe this is for the physician to decide, but why would you give a nitrate versus a beta blocker if it's making, if you want to slow things down and perfuse the body
they
with
have a
oxygen, why would you want to give them a nitrate and cause tachycardia?
But if they have a slow heart rate for some reason, you don't want to drop people.
Well, that's true.
Oh, yes, it depends on all what's going on. If I have somebody who is known to have angina or angina, I'm gonna give them that nitrate because in that moment they need that medication to keep them open. Okay, I'm going to give them a beta blocker if their heart rate is too fast, the heart is working overtime, and they're not perfusing. The main thing is perfusion. So whatever medication we can give to keep that heart perfusing, not only the heart, but we have lungs, we have brain. They talk about the kidneys, right? That diuretic is probably going to work twofold. It may be to help decrease the fluid load, but it may also be kind of help those kidneys to keep working, keep kicking in.
They won't do them at the same time, right?
Yes, they do. Oh, yeah, wait.
Do they give them the same time, say they're for an coronary artery disease, they come in and they're gonna give the nitrate because to clear those arteries and try to get their blood pressure down, but then they'll give them beta blocker to get that tachycardia down?
Yes. Yep. Nitrate perfusion. You need to open the door. I need to open the door. Okay. If my arteries are not dilated, that blood is not going anywhere, right? So it doesn't matter if I give them a beta blocker because it's really counterproductive if you think it out, right? I'm making the heart work even harder, but the avenue that I need for the blood to get through is still constricted. So we're gonna open up those coronary arteries, okay? Drop that blood pressure kind of a little bit and get some perfusion going on. But it could be my heart rate still a little tachycardic. I've got oxygen now. I'm happy. Yay! All right. But we still really don't know what's going on with this heart. If it is an active MI, I need to conserve what muscle that I have left, okay? So then we're going to give them a beta blocker. Kind of slow things down, keep that heart rate down, that blood pressure down, until we can get them over the hump and figure it out. But these are going to be your stable medications. These are going to be things that they are going to have to be on some people for the rest of their lives. We talked about beta blockers being in the lungs, so why do we need to look out for bronchoconstriction?
Then the gases won't pass through.
Yeah, beta.
Right, breathing, what you're saying, the oxygen. So we have to keep, so this is a common side effect, right? What medication do you know of, maybe you take it or your children take it, that we give to help people? Albuterol. Works on what cells? Beta cells. So someone who gets an albuterol treatment, what happens to their heart rate? It goes up.
So then you block it.
No. No. That is an expected reaction, okay? Now if there's 70 and they go up to 100 or 110, I'm okay with that. If they're 70 and they jack up to like 150, we got a problem. It's not the albuterol. But this is just so you guys can understand that everything is all interconnected. And some things are expected, and that's okay. But if it goes above your expectations, then we need to be thinking about something else. Would you?
So if they become asthmatic, they would give a buterol with the other two medications as well. Because my question when I've been studying these things is a lot of asthma or COPD symptoms is the same as heart issues. So how do they determine if it's coming from their asthma, if they have a history?
We
or
don't
from their
care.
heart?
Fix it first, and then we'll figure it out later. So whatever they are presenting with, that's what you fix.
So you could give a beta blocker to somebody that had asthma.
If it's not their asthma and it's their heart, I'm gonna fix the heart. If their asthma kicks in, I'm calling
Then give them
respiratory. I need to
albuterol,
read
they
the
can't
treatment. Yeah, whatever. Just so whatever the problem is, that's what you're gonna fix. And if we muck something else up, as long as I save their life and I go back and fix it, if I throw them in an asthma attack and prevented them from dying, that's a good thing to me. So we'll just give you some albuterol, some soluble and send you up to IC. You'll be You live to tell about it. Calcium channel blockers, PINE. Those are your calcium channel blockers. All right, here's your exception to the rule. Diltiazem does not end in PINE, does it? But it is a calcium channel blocker. So amlodipine is Norvasc, nifedipine, Procardia, Adalat, Diltiazem, Cardizem, Tiazac. Those are your roots. Oh, so remember we were talking about the SA, the AV, and all that stuff? This is where this works. We were kind of talking about what channel are you watching. We were talking about sodium, potassium, and calcium. How should calcium cross the membrane? Slowly. So if we are giving a calcium channel blocker, that means the calcium is doing what? It's going too fast. And if it is going too fast, what's going to happen to the automaticity of the SA node? It's going to increase, it's going to fire, right? And then the AV node is going to be like, okay, wait a minute, something's going wrong. I'm going to intercept all that I can. And then this person, where are these located? SA and AV. Okay, this person may come in and say AFib, atrial tachycardia. So think of what goes on at the upper part of the heart. How might this person, what symptoms may they say they have? Butterflies, palpitation, shortness of breath. What else? Okay, irregular heartbeat. Are we perfusing? So they're going to be complaining of what? Fatigue. All right, they might be cold. Okay, you put that person on the heart monitor, and you're like, ooh, is it this? Is it that? We may give them a little cardizem.
Would their calcium be increased if we did labs, or would it just be something going on
Just be
with the
electrical.
Okay.
Because of the
just the way it's
polarization
working?
of the ion.
So it's not that they have increased calcium, it's that the channels are not regulating correctly.
Right.
Right, it's too much calcium and not enough receivers. So it's crossing too fast.
But it's not like they have too much calcium in their CMP or anything like that. But
Probably not initially, unless it was some injury to the skeletal muscle and that caused the calcium to elevate that way. But usually it's just because for some reason it's excited and it wants to get over to the other side. But knowing all that, would you not want to monitor your patient's calcium levels? Okay, so that's something that you would keep at the back of your mind.
because I had AFib once, and they said there's like 50 different reasons for AFib. There's no real cut and dry for it. But they said that my potassium was low, and it might have sparked some sort of arrhythmia, and I did have a Red Bull that night, which I don't do anymore. They're medicine.
Did you listen to
And alcohol, yeah.
I'm like, you have just a Red Bull.
And so, I mean, I went through the whole cardiology, like had everything done, and he said it was a fluke. Like, we probably will never have one again, but he said for some reason that night. It's good, so.
Don't do that. And I'm glad you did tell about that. Because those little things, I mean, it may seem so innocent, but people really don't understand if you're stressed. And other little activities that you do, that one little, I forgot what it's called, but when they mix the Red Bull and vodka and then take the shot or whatever, and they're like, and you try to pull them down and strap them to the gurney. Their heart rate is 150, 170. I'm gonna die. I'm like, oh. Just stop the madness. Drink a Red Bull, wait a little while, get something to eat, get a shot of vodka if that's what you must do, and then go home. You don't drink 5 of them and then think you're going to have a good day. It's not going to happen. Okay. So then we slow them down, figure it out, and some people convert out of AFib and never have it again.
Yeah.
Find the problem, you fix it. Some people go in and out of AFib. It's called paroxysmal AFib. One day they're in it, one day they're not in it. Some people live with it for the rest of their life. But once you figure out what it is, this is probably the medication that they're going to be on, and life is good. Yes, ma'am.
So basically, so I can kind of
So you're saying that if there's too much calcium, then it's going too fast. It increases the initiation of the SA node, which there's not enough receivers on the AV node to.
They're gonna try to catch it. So somewhere somebody's not going to catch that electrical impulse, right? So it's doing what it's supposed to do, but it's kind of like you play tennis and they got the automatic ball, and at first you start it off and then you hit them. Yeah, and then you're kind of like, okay, that's a good analogy of what's going on here of those calcium cells trying to cross the membrane. And the heart's like, well, I'm just gonna beat with whoever I can and let them figure it out. Yes, ma'am.
So, the other night at work, there was a lady that her heart rate was like really high. I mean, it was like off the charts high. And then within like 10 minutes, it dropped down to like the 40s, and you saw the pause. So she was actively like having a heart attack at that moment. Because it was like pause, and then it was like, and then pause too, and we were like, everybody was like, ah. Yeah. Okay.
So when the heart gets irritated, the heart is irritated. But there are little signs that you need to be wary of and things that you need to look for. And sometimes somebody can be sitting, Patricia can be sitting here talking to me, and I'm talking to her, and they're monitoring, ding, 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 and I'm like, I'll be right back. Like, my chick is having a heart attack. And we need to fix her. She's like, oh, my chest is just a little tight. No, sweetie, it's about to close. So we have to, and it could just happen just like that. So was she sleeping or she was just?
Well, at first they started kind of freaking out, and then they saw the band, and oh, she's a DNR. So then it kind of calmed down.
Oh, God. Oh, it's okay. She's a DNR. Don't worry.
Don't judge.
Oh, my God.
She will be there one day.
Yes.
Yes, ma'am.
Okay. So you guys,
At work.
they're gonna
No, they
evacuate
aren't
the heart,
hospital.
the whole. I mean, like it's skeletal muscle too with the calcium, right? So
Yes.
they could have like muscle cramping with this, or would it be more relaxation, or? Because I was given Procardia for preterm labor, and to help relax things. So it relaxes like muscles as well. So
Well, think of the uterus. It's smooth muscle, right?
right.
Okay. So right here, your function is to decrease the heart rate workload, dilate the smooth wall of coronary arteries.
Okay.
So you got arteries where? Everywhere. And that uterus is really working hard, and it has a lot of arteries in there because it's supplying blood to a whole other little person in there. So that does make sense. So these medications will be used in different areas for different reasons, but you can logically think it through as to why it will work on that specific organ, okay? So here you have your decreased BP with IV administration, an AV block, bradycardia, GI effect, all right? Why is the AV block a side effect?
Slowing down the conduction.
All right, we're messing with the automaticity, right, of the SA node. So you can have an SA-AV node block, all right? So that's like way up here in fourth block, but that's just something that when you get there, you need to be aware of. All right, what medications have we learned about thus far? Statins. What are statins for? Where do they work?
Lower your triglycerides.
All right, so it works in the liver. It lowers my LDL and what else? Increases HDL triglycerides, right? Side effects. Muscle crash. All right. Myalgia. The nicotinic acid, which is which B vitamin? All right. How does that work?
Same thing except for the developing
Okay. Side effects.
same flushing, gout.
All right. So you got two classes of medications down right there. What's the third one we learned about? Nitrates. What's so special about those? Dilates what? Coronary arteries. If your patient says they have a headache after you give them some nitro, is that okay?
Yes.
All right. How else do you know the nitro is working? Blood pressure goes where?
Down.
Heart rate goes where? Is that expected?
Yes.
Are you excited yet?
Yes.
Let me throw him a question.
Oh,
There we go.
This person is at home and is taking sublingual nitro and states to you, "Oh, I have to have this on me at all times. So that I won't forget it, I put it on my windowsill." Why is that a problem?
So December.
It decreases the intensity, the potency of the medication. That's why it's in a brown bottle. So you need to tell the patient, store it. If they're gonna store it in a cool place. People usually take it in a pocket where the sun is deflected. Another thing you need to tell them, if you are at home and you've taken 3 and you're in pain, don't wait around, call EMS.
Don't get in the car.
Don't drive yourself to the
Drive yourself.
hospital and kill yourself and somebody else.
How does this one dilate the smooth wall corner? I don't try to put that together.
Okay, y'all, I'm a nerd. As a matter of fact, I'll find out for you.
Okay. What did she ask?
She asked, how does it dilate the smooth wall of the coronary? Well, where is the smooth wall of the coronary? It's in the inside of the coronary arteries, right?
Right.
So it just kind of opens it up. So come in. It's in there. Okay. Oh, just leave it. Just go with it.
just know it.
Just know it. Don't get caught up in a who's, how, and why, because just say, this is what you need to do. For that. Beta blockers. What's so special about those?
What's wrong?
They block what?
I'm just talking.
The sympathetic, which one?
Beta cell.
Okay, you can't get that wrong. It's a beta blocker. So you know they block beta cells. All right, what happens with those beta cells? What is our patient going to hopefully come around? How do we know they're coming around?
They feel better.
They feel better because their heart rate is what? The workload of the heart is? What happens with that blood pressure? Okay. All of these medications, including these, predispose our patients to what? Orthostatic hypotension. All right, so keep all of these teaching things in mind. Another thing I need to tell you about nitroglycerin that I forgot to tell you, expiration dates are important. One big old giant dusty block of nitro is not going to help you if you have chest pain, okay? So they need to keep in cool, dry place, stored in the original container. I used to do home health, case management for the Milwaukee County. I went to a patient's house and she had a candy jar. That was not candy. She had her nitro, she had all her, I was utterly mortified. Cause I saw like the little mints in there and I was getting ready to get one. I was like, what the? Oh my God. I said, well, could you explain to me what's in your candy jar? She was like, oh, this is my heart pill. And this is my, would you like a mint? Cause I got to drive out of here. And I can't be on the side of the road with my blood pressure 0 because I have to mint. So that was a patient teaching moment. My next question to her was, do you have what? Grandkids, you can't have them babies coming over here digging in that dish. You're going to jail because you killed them. You need to teach them. She thought that because she had, decreased mobility and she had her whole little system down. But that's a huge safety issue.
Sure, with all the organizers too for the pills.
Yeah, that was next on my list. I was like, yeah, I'll be back tomorrow. And we're going to set up your pill organizers. What do medications look like to little kids? Candy. They're different shapes, they're different colors have different flavors. Why not try some of Grandma's pills?
So is nitro a sensitive one?
Yes.
What would you do then? Are there pill containers that are light sensitive?
I would keep that in its own original
What if they
container.
can't open it though?
We'll figure it out. We'll work it out. Because if you put it in one of those containers, you can lose it. You see the bottom of your own purse. What do you find in there? Gum, Tic Tacs from 19 whatever. Right, a little thing, but like dexterity, whatever, we could work it out. So if you're that home nurse or that case manager or whatever, you can work it out with your patient so that they can be
Figure out what they can do.
Yes, what they
If you get pulled over with loose pills in your purse, that's felony.
I mean by nitro, she get in the bottom of the purse.
Good times.
All right, let's take a break and we'll finish up these medications. And
Miranda, I found it for you.
What'd you find?
About the calcium things.
Oh.
It's like the electric, remember when we did muscles and EMP and stuff? There it is.
Yeah, we'll just go over some stuff. Like all the drugs.
That's hilarious.
All right, let's finish this up.
That's awesome.
That's good.
Okay, your ACE inhibitors. Your angiotensin converting enzyme inhibitor. Okay, remember this because you're going to hear this again when we talk about renal. You're going to hear it again when we talk about diabetes. These are your ILs. Lisinopril is going to be your generic dextroestrade, enalapril, and Basitec. POIV. So this does not let angiotensin 1 become angiotensin 2. And because of that, the kidneys excrete your sodium and your fluids, and this is going to decrease our blood pressure and our cardiac workload. So does this work on the heart?
Yeah.
Not directly.
Not directly, in an indirect way. Where does all this happen at? The kidneys. What did I tell you at the beginning of this lecture? What percentage of your cardiac? 25%, all right? So,
25% of cardiac output, is that what you're saying?
yes, your kidneys receive 25% of your cardiac output. So our kidneys are kind of like our fluid regulator, right? Where there's sodium, there's what?
Water.
All right. So because we don't have angiotensin 2, we're going to excrete our sodium and our fluids. This is going to decrease our blood pressure and overall workload of the heart because we don't have all that extracellular volume that needs to get circulated back to the heart. Someone who is hypertensive, hypertension is not good for the heart, it's not good for the brain, and it's not good for the kidneys, okay? Someone can take all of these medications. Maybe they don't have any kidney problems yet, but we're going to give this to them to preserve some kidney function. Same thing when we get to diabetes, you're going to hear that again also. Diabetes destroys macro and microvasculature. So maybe they don't have hypertension per se, but we're going to put them on this ACE inhibitor to preserve some of our kidney function. ACE inhibitors. Decrease blood pressure expectation. Is that an expectation?
Yes.
Why are we watching our potassium levels?
When you lose sodium, the potassium goes up.
All right, so you lose sodium, you gain potassium. Increased potassium levels cause what? Dysrhythmias, okay? Dry cough. If you have a person that says, started this medication, I just have a dry cough. They can't drink it out, there's not enough mints or cough drops. It's just one of those nagging, dry, hacking coughs. My first question is, did your doctor give you new medication for your blood pressure? Yes. Is it lisinopril, zestrol? They're like, how do you know? No, you look smart. Okay. They should not abruptly stop that medication. Once they figure out that that's a problem, the doctor should then immediately prescribe them something else, and they transition and start taking that new medication. So hopefully there's not a lag in between the ACE inhibitor and the new med. Angioedema, what's that? Your angio? It's just fine. Well, yeah, you can have it like that. Usually someone who takes an ACE inhibitor, their lip will be very swollen. It's fluid filled. It kind of looks like they took a hypodermic needle and just puffed it up with fluid. It's very different than like an anaphylactic, kind of sort of like that a little bit, but just not systemically. Yeah, the lips. It could be angioedema of the face, just kind of real puffy looking. Usually, it's the lip, and they'll take their hand down, and you're like, oh, they're running angina. And again, you look really smart because they think that they're not.
Can I ask a question on this one? My
Yes.
husband takes Lisinopril, and he swears that he goes to the bathroom more because it's getting rid of all those fluids? Would that cause?
So it has a
Something
diuretic
like that?
effect. Yeah.
Okay. Is that like a normal side effect, or is that just?
I'm gonna let you answer that.
I would think it would be, but I didn't see it listed, so that's why I
But
asked.
is it a side effect or is the medication doing what it's supposed to do?
The function of the medication.
So when it comes to like the dry cough and angioedema though, that's not side effects you want to like increase blood pressure, that's okay, you can deal with that. But you wanna switch them when it comes to
Right.
those two.
Because then that's affecting that person's. Well, you know they're not gonna take the medication. If you had a medication that gave you a dry cough, would you take it?
Oh no.
Made your lips look like Angelina on steroids? So then you need to switch it. Your ARB, angiotensin receptor blockers. Okay, anything with a blocker, just know what it's supposed to block. This one blocks angiotensin 2 and prevents the release of aldosterone, so it's going to decrease our fluid overload. These are going to be your TAN, T-A-N, Diovan and Valsartan, and the rest of those. This is my caveat to medications. Say the one that you can pronounce and know what the other one is. Okay? I can't say Avpro, but I know it's a ARB by looking at it. Alright? These are given orally. Again, they have similar side effects as what medication? As your ACE inhibitors, okay? Except this one is angiotensin. Now, yes ma'am.
So back on the ACE inhibitors, just really quick, it says it prevents the conversion of angiotensin 1 to angiotensin 2. Is that because angiotensin 2 preserves fluid and you want to block that so you're losing enough fluid? Is that why?
Yes, because we want to decrease the extracellular fluid volume in the body.
Okay.
Decrease the workload of the heart.
So this one just lets it go to angiotensin 2, but then doesn't let it work once it's on 2.
Well, doesn't aldosterone, is that the one that constricts the?
What is aldosterone? I don't answer questions.
Aldosterone's a vasoconstrictor.
Boom.
So you
Right.
I say it. Oh.
Alright. I don't mean to be cruel. You guys ask me questions, I'm gonna answer it back to you. Wanna know why? Because if I give you the answer, then you won't remember it. But if you spend time searching, looking for it, you will remember it and you can connect the dots and make it make sense to you. So if you're in my clinical group, I feel sorry for you. Because I'm not answering any of your questions. But I will guide your thinking and I will make you dig in there and get it. And by the time you put those pieces together, you will be wanting to turn cartwheels down the hallway. That's what I'm looking for. Because nobody's going to be at the bedside telling you answers. You're going to have to know how to put those pieces together. Your patients and the family are expecting you to know the answers. So there's no better time to learn how to find the answers than right now. All right, so we know that aldosterone is a vasal what? Is this going to be good for us if we are trying to decrease our blood pressure? No. So we're going to stop that angiotensin 2, which is going to prevent the release of aldosterone, and it's going to decrease our fluid overload. Now, persons of African American descent or of mixed heritage, we need to start thinking more globally, okay? Nobody is just one ethnicity anymore. This medication is not as effective if it's not in conjunction with something else, okay? African Americans' kidney makeup is totally different than any other ethnicity. African Americans and the medical community aren't great friends due to mistrust, distrust, and other things. So when medications are trials, they are trialed on European Americans. And that is what the literature is based off of. But you have so many other ethnicities, so many different other ethnicities, that blood pressure for African Americans can be hard to control because we weren't included in those trials. So sometimes for someone who has high blood pressure that is out of control, it's going to be trial and error until they find a combination of medications that work for that person and their condition to get that blood pressure down. So if you supposedly had a question that stated you had a 50-year-old African American male who is hypertensive, and the doctor prescribed, I don't know, what's one of those medications? Diovan. What could you expect? What other medication could you expect the physician to order?
Diuretic.
Okay, maybe a diuretic. What else did you learn about? An ACE inhibitor. So you can see that whatever the doctor feels, usually it's an ACE inhibitor sometimes. It could be a diuretic, all right? Very seldom to rarely will they give an African American this by themselves. And if they are, and they've kind of watching them for a little while now, blood pressure is not going down, then it's okay for you as a nurse to suggest, maybe we need to try some adjunctive therapy. Maybe we need to give him or her something else to go with that. So those are some things that you guys need to be aware of. Before we talk about angina, diuretics. You have potassium wasting and potassium what?
Saving.
What are potassium sparing? Give me some names. You have potassium wasting diuretics. You have potassium sparing.
So are these considered, is the ACE inhibitor
No.
All right, Cater back there. What's Cater?
Potassium, right?
The word
sparing, isn't it?
Cater is potassium.
Yeah.
Oh.
That's why I was joking, yeah.
Oh, I'm like, okay, but it is what it is. So if we're giving K-Dur, what medication might they be taking as a diuretic? Lasix, yes, they go together. So Lasix is going to be potassium wasting. Spironolactone, what is that? Okay, write it down.
Spell that.
Spirno, something like that.
Okay.
This was Spirno,
No.
and you get it. It's spironolactone. That is going to be one of your potassium-sparing diuretics. Then you have a group called your thiazides. You can have HCTZ, write that down, because I'm not spelling out hydrochlorothiazide. That's not happening.
Okay, what does he want to write back?
HCTZ. It's hydrochlorothiazide. That is going to be a potassium wasting.
So those two go together? That would go
With Cater.
No, like, would it go with the spirulactone or whatever?
No, that one.
That's sparing.
That's sparing.
What's this one?
Spironolactone is potassium sparing.
So it would go together, no? So this would go with like Lasix?
Yes, Lasix,
Oh.
HCTZ go together. Now they work differently though. Lasix is a loop diuretic.
Why would you give two kidneys for?
So go back to your pathophysiology. This is what I want you to do.
Same category.
It's the same category, but not the same medication. So Lasix is a loop diuretic. So remember, way back in the day in pathophysiology, you heard this thing called a loop of Henle or something like that. Okay. So you have your exchange of sodium and something else that happens up in there. All right. So Lasix does whatever. So it must get rid of potassium and whatever happens. Go back and review that because I'm not gonna set up here and lie to you and confuse you. So go back and review that. All right. Hydrochlorothiazide or hydro works a little lower down. So you have the loop and then you have the tubules and all those things. All right, so you have to kind of go back and review that so you understand why it's potassium wasting or it's potassium sparing. Okay. These medications can be given in conjunction with all of these things that we have here. Or they can be used by themselves to control blood pressure. So for me, I don't have a heart problem. I have a fluid problem. I retain fluid. So if I retain fluid, what's going to happen to my blood pressure? It's going to go up, which is going to make my heart do what? Work harder. Okay? So there's nothing wrong with my kidneys per se or my heart, but I just retain fluid. Okay? So I take a low dose of HCTZ. So we just learned that HCTZ is potassium what? So there you go. Bananas. Where else can I find potassium? Cater. What you think? Cater. All right. Where else can you find potassium in your diet?
Broccoli.
Avocados, broccoli, green leafy vegetables are what?
Iron.
And what? Vitamin what? K. Don't confuse potassium with vitamin K. Two different things. And it's easy to do because they're both K. All right? So how do you know someone's potassium is low?
Which muscle cramps?
Muscle cramps, okay? What else?
Diarrhea. No. Yeah.
Diarrhea or abdominal pain? It'll be low.
I have a dysrhythmia. You might have dysrhythmias.
Might have some dysrhythmias.
So if you're not taking an ARB, you would want to give a potassium wasting with it.
Yeah.
In some people.
And something. So this is how you draw, the electrolytes, your fluids and electrolytes, and how these medications work, and where they work, and why you have to monitor these labs, and if I'm giving this, then I'm giving that. And then sometimes doctors don't speak to each other. Go figure, okay? So they're giving them this for their lungs. They're giving them this for their heart. They're giving them this for their stomach. And then they present with all these symptoms, and you look at the medications. This doesn't go with this. This doesn't go with this. This doesn't go with this. And this is why they're here. So I need all you two to go to lunch, figure it out, and then come back and talk to me so we can get this person where they need to be. But that's our job, okay? So all these medications are working, and we have labs that we need to be wary of. DIDGE is something that we can give to help with the contractility of the heart. Digoxin. Digoxin is in your book, and I think it's going to be part of stimulation. I'm not for sure. Can't remember. Read up on DIDGE though, because DIDGE, potassium, DIDGE and potassium go together too. At one time, DIDGE was killing all the old people. Literally. Because of the toxicity. If it's over 2, I think, 2.0, then they become toxic. And they see halos and all these other things. But DIDGE was not a medication that you can just stop. So they had to scale them back. And eventually they made some new medication and slid that in. And now we're starting to see digoxin come back. So go back and read up on it because you may see it in practice. Remember you had to learn how to listen to an apical heart rate? DIDGE is one of those medications. You want to listen to that apical heart rate. If that heart rate is less than what? You don't know. 60, then we're going to hold that medication. So if you have DIDGE on your MAR, those are the things that we're going to expect for you to know and see you do before you give that medication. Angina is the big fancy name for chest pain. And instead of me boring you with how it works, showing up there?
Angina is a squeezing chest pain that occurs when the heart muscle isn't getting enough blood. The heart is a muscle that pumps blood around the body. Like any muscle, the heart needs an energy supply, mainly oxygen and sugar, which it gets from the blood. The arteries of the heart, called coronary arteries, carry blood to the heart muscle. Every part of this heart is getting a good supply of blood, so the heart muscle is a healthy pink. Okay, so what happens when a buildup of cholesterol-filled plaque in one of your coronary arteries gets big enough to reduce blood flow? One part of your heart muscle gets less blood than before. You can see the pink fading. If you're at rest, your heart is not pumping hard. So even though blood flow to the heart is reduced, the heart muscle is still getting enough blood to quietly pump away, and you won't get angina. But if you exert yourself, like walking up a hill, your heart really starts pumping. Without the blood it needs to work this hard, it will scream out in pain. Though painful, an attack of angina doesn't injure the heart, because when you slow down, your heart muscle starts getting the blood it needs again. But a person with angina is at increased risk for a heart attack, which does injure the heart. We have a video and common questions and answers about heart attack in the conditions section. We have common questions and answers about angina in the conditions section as well.
That is a misnomer. I can't find
Does that help explain angina? A whole lot better than I would have. And it's something that you can see. And it's visual, okay? So what we have is the increased demand for O2, but we don't have enough myocardial supply, right? So that's why he said at rest, it kind of subsides. But when you increase the oxygen demand, it's going to scream out. And that's our form of chest pain. And we saw that it's usually caused by atherosclerosis. Now, you have different types of angina, which can change the game a little bit. Atypical, meaning there's really no rhyme or reason as to why we have this chest pain, okay? They have it, it's real, you don't ignore it. Because what did the gentleman say in the little vignette? It can cause a heart attack, okay? So this is someone that maybe we gave him a nitro, it went away. Maybe let's work them up and figure out if we can give it a cause. Stable is going to be someone who, the young man that was walking up the steps, okay? It screamed out, he stopped, his body was able to compensate, the heart slowed down, and then he was able to finish going up the flight of stairs. If he ignores that, where do you think he's going to go?
Unstable.
Yes, because he's going to be unstable. Unstable is the same as your acute coronary syndrome. That's somebody who, whenever you hear the term unstable, think of symptomatic, okay? You can have stable chest pain. You can be hemodynamically stable. Your blood pressure's okay. Your heart rate's okay. You're just having some chest pain. We give you some oxygen. We give you some nitro. We know you might be in for 24 hours for a full cardiac workup. Maybe you'll go to the cath lab later on, okay? That's our stable person. But just because they're stable, we're not gonna get, they're gonna get excited like you guys did, but he doesn't have a DNR bracing on, all right? Unstable, this person's heart has had enough. I've been telling you this for 6 weeks. I've been telling you this for 6 months. You're no longer paying attention to me, so I quit, okay? This person may have that crushing chest pain. Or if it is a female, what might she say? Back hurts, indigestion, I'm tired, I'm out of sorts, I just don't feel well. Those are the worst words anybody can say to you. I don't feel well. If somebody cannot describe to me how they're feeling, I'm thinking the worst, because that's usually what's going to happen to them, okay? This is the person that we are going to put them on their monitor. You're going to learn about Mona after this slide. Tell you what Mona is. This is somebody that if we can get them to the cath lab, remember we talking about that golden time from door to door within 90 minutes, 60, 15, however you can do it, this is the person. Because we learned earlier in our review that you get to the cath lab, the result is to open up that what? That artery and give us some oxygen. Time is muscle. The more time you waste, the less muscle you have, the less effective this heart is going to be. Variance is one of those things that it depends. Maybe they're mowing the lawn, it gets better. Maybe they're resting. There's really no rhyme or reason. It varies. Whatever, they can be resting, they can be sitting, they can be standing, they can be doing nothing. You just don't know.
How is that different than atypical? Because that was the one that was no rhyme or reason too, right?
Atypical, usually you can kind of sort of get an idea as to maybe what precipitated it, but not necessarily like pinpoint. Variant, yeah, is what's his name? She says his name very well. Say it. What?
Prince metal is a type.
Prince metal is a type of variant. Variant is a little dangerous though. Because there's no rhyme or no reason to it, that's somebody that can go into an acute coronary syndrome. That literally their coronary arteries will have a spasm. So, they're having chest pain, there's no rhyme, there's no reason, they're symptomatic. That's a little more scarier than somebody that's atypical. Does that help clear that up for you? Intractable is someone who, no matter what you do, it's not going to go away. And it could be a nerve damage thing. It could be that the heart is just so diseased that it's going to be its normal state. When I worked at Casa Grande, we had a patient that would come in like that, and there was nothing that they could do for him. His collateral circulation was probably what was keeping him alive at that point, and he ended up being on a pain pump for his cardiac pain. There was nothing else they could do for him from a cardiological standpoint. It was just a sequela of the damage that his heart sustained. It's real. You treat it. You're still going to do what you need to do cardiac-wise, because it could be that one time that you ignored and poo-pooed it, and he's actually having the big one, okay? Post-myocardial infarction, these are the people that will have another MI on you in a minute and die. So they sustained a heart attack, okay? We got them over the hump. If they start complaining of chest pain again, then we know we're going down the wrong road. We need to really kick it up a notch.
I'm throwing out a question. Okay, I'm trying to get to class. I'm the lecturer that day. I'm coming way out from Cairo in a parking lot out there. And I get here, and I'm up there, and I'm about to start lecture, and I'm sitting there, and you notice I'm diaphoretic when I first get here. And someone comes up to me, and they try to get my hand, and I'm shaking. I'm a little, confused, diaphoretic, confused, can't get my breath. This lasts 30 minutes. I'm trying to give you lecture, and am I stable?
No.
That's it. The symptoms that you have they do not subside within a given parameter, that person's unstable. If that ever happens to me, what are y'all gonna do? Is there a phone here?
We have phones.
A lot.
No, this is what you need to do. You need to see if someone needs to hightail it up to the nursing building because PD needs to know on campus. Anybody come out, even emergency. But that ain't gonna happen to me. Praise God.
All right, your assessment. Hey, we talked about PQRST, all right? This is kind of very important when we're talking about cardiac pain because that kind of helps us decipher, when their activity level is high, then that might let me know that maybe this is somebody we need to admit for further diagnostic workup, okay? Weakness, numbness to upper extremities, all right? So remember I was telling you when I went to nursing school, we were told that you had the elephant sitting on your chest and the pain radiating up to your jaw and coming down your left arm and all of that. Well, that may or may not be true. I had a gentleman tell me, he said, it just feels tight right here. We had a big snowstorm. He's a big, hefty, burly guy. He shoveled his driveway, shoveled the walkway, shoveled the neighbors, and he was like, I don't need to go. And all he was complaining of was this right here, just a little tight. Beautiful vital signs. Got those cardiac enzymes back. I thought I was going to explode. He was having a heart attack. And the only thing he was complaining of was just a little tightness right here.
How long does the symptoms last? I mean, if people aren't feeling good, like a week, 2 weeks, a couple days?
If they're lucky. It depends on what's going on in that heart, how many vessels are occluded. If it's the big one, we may not have time. If they, it could be a day, it could be an hour, it could be a week, 2 weeks. I would go to church with a lady who she was like 3 days before she finally went because she thought it was indigestion. And then they told her, had she not walked in the door when she did, she would have died. So again, patient teaching and all of those things are very, 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 very important. Shortness of breath. We talked about the increased blood pressure and heart rate. In this case, NVD is nausea, vomiting, diaphoresis, not diarrhea. Pallor. Okay, so their color. If they're ashen, if they're pale, something's wrong. Okay, and anxiety. There's a caveat to this. A diabetic, will they feel cardiac pain the same way as everybody else? Why? Diabetic neuropathy, okay? They may complain of atypical chest pain, but you need to know that this person is diabetic. I'm not going to poo-poo this. We need to put them on a monitor. We need to get those enzymes ran. And they may complain of something totally different. They just may say, I don't feel good. It hurts a little bit, and they're having a massive heart attack. So those are some of the things that you need to be wary of. All right. Yes, sir.
So, I've always heard that you're supposed to, chew 2 aspirins to help. Is it 5? I thought it was 2. Anyway.
325.
Huh?
325. Not enteric coated.
Like bare aspirin.
A bare aspirin. If you have baby aspirin, it's
It's like
5.
5 of those, yeah. 86. Those are 80, aren't they?
81. 81.
So, but that's to decrease like
We're gonna
clotting.
get there. Oh, that's
Oh,
all.
okay.
Oh, that. We're gonna get there. We're on our way. We're diagnosing now. That's the next. We're gonna get there. Just
Rob
hold
is
that.
assessing himself.
All right. So we're doing our assessment.
I need some aspirin.
He knows. So we have some diagnostics. Your labs are gonna be the same as your coronary artery disease, right? There's this thing called here a C-reactive protein. It's just a protein that is released when the heart is injured. Your procedures, you're going to have an EKG, a chest x-ray, cardiac cath, we talked about that, and a stress test. Stress test, they will be admitted to the hospital, and they will do that on the floor. You as a nurse, if your patient is going for a stress test, you need to do the same thing that you did for that cardiac cath. You're going to assess them. You're going to look at those meds, those allergies. That patient is NPO, which means what? All right, for 4 hours before the test. They are to have no caffeinated or decaffeinated beverages. What is decaffeinated? All right, it's still caffeine in it, okay? Nothing, no tea, no coffee, no Jolt, no Red Bull, no chocolate, none of that.
Is this saying like 12 hours before you need to cut them off of all this stuff, and then the 4 hours before nothing at all? Because obviously they wouldn't be having caffeine 4 hours before because they're not drinking.
Right. But if I was admitted, say at 2 o'clock in the afternoon, by the time I get to telly, it might be 3:30, 4 o'clock. Then I know from the time that I got in that ED, that's when I started my no caffeine. And then 4 hours before that test, that I'm gonna have nothing by mouth. If it's outpatient, then they can be a little more stringent on it, but usually from an inpatient standpoint, you just take them from where you get them and monitor things from there. Physical assessment pre and post stress test, is that important?
Yes.
All right, because you would like to know what they were before and what happened when they came back. An MI, heart attack. Main thing you need to know, ischemia can cause necrosis. Necrosis is death. We talked about this already, right? The top is your normal what? Sinus rhythm. PQRST. Everybody's happy. What's the one below that? What's so special about that? All right, so that is the heart telling you, look, I can't do it anymore. I don't have any oxygen. Fix me. Or we go where? That is correct. All right. ST depression. What does that mean? They could have had a heart attack, right? We got some injury going on. They may not be actively infarcting right now.
Could that be from angina?
It could be, or maybe a massive MI from before. But this T wave inversion, I know, is a previous MI. Mona greets you at the door, okay? Morphine, oxygen, nitro, and aspirin. Now, Professor Denson was alluding to a medication. I want to tell you what they are. Viagra, Cialis, all those things. If they've had those in the last 24 hours, one of those persons they may not be able to get. And that's going to be your nitro, okay? So you need to, when you assess those medications, you need to ask them those questions, all right? Do you take anything for erectile dysfunction? So you take a little blue pill? Yeah, all right, okay. Now I need to know that. All right. Morphine. Morphine is given for what? Pain. Why do you think we give morphine in this case?
Slow down the
Anxiety.
Anxiety. It actually kind of helps with smooth muscle relaxer, okay? Oxygen. Why are we giving them oxygen?
Don't have it.
Right, because they don't have it. Let's give them some oxygen. Nitro is going to do what? Dilate those arteries. Aspirin is going to prohibit what? What do you think?
Thins the blood.
Platelet aggregation. Aspirin works on platelets. Remember that little video they showed us of how the blood flows and the platelets and all that kind of stuff going through there. Then we have the little yellow streaks, all right? So platelets adhere to that. Mona greets every chest pain at the door, all right? In my world, if I have somebody that has chest pain, I know I'm going to write this down in this order. First thing I'm going to do is I'm going to put them on a monitor. Before I give any medications, I need to know and see what I'm working with, right? I can't just go willy-nilly passing out meds and their blood pressure is 20/10. Guess who doesn't have a job or a license anymore? That would be me, all right? So you put them on the monitor. If they're having chest pain, we know they are what deprived? So let's give them some oxygen. I know I have the potential to give some nitro and some morphine, and caveat to morphine. Morphine also drops your blood pressure, okay? So why don't we check a blood pressure before we do that, all right?
If the blood pressure was like borderline low, would you pick one over the other?
I would talk to the physician and see, because I can fix that blood pressure. I can load them up with some fluids if I need to. But that's the physician's, determinant. So I check my blood pressure. My blood pressure's okay. I'm gonna give them that nitro first. Then I'm gonna give them that aspirin and have them chew it. Not swallow it whole. If we swallow it whole, are we defeating our purpose?
Yes.
All right, we need it to be broken up in its purest form. They just swallow it on down. Then I might give them a little tube of morphine. That's probably more for my benefit than for theirs. All right? Hopefully you wrote that order down because you may see it again.
So, quick question. I guess kind of obvious, but so if you have a patient come in like that, it's fine because it's emergent that you just start these things and then get an order later.
Emergency nursing, I was telling somebody up here, is very different than floor nursing. We have an autonomy like no other. Our physicians expect us to know what to do and go do it. But within that autonomy, you only go so far. So I may go to the Pyxis and pull these meds and have them in my pocket. Did you give me nitro? No. You want me to give one? Yes. Here's your nitro. I have 2 of morphine. Want me to give 2 of morphine? Yes. So I know that I'm anticipating the needs of my patient and the orders that the physician is going to give to me. I'm going to have those things ready to rock. Whenever he says it, I'm going to pull it out and we're just going to do what we're going to do. On the floor is a totally different animal, okay? You have different procedures and policies in place. But some things don't change. If they're having chest pain, you give them that oxygen. You get that crash cart and you have it outside that door. You do whatever you need to do within your unit's protocol and then go back and get the physician to put those orders in. Make sense? So it's not like you're working rogue, you don't have orders, but you have protocols or order sets and things that you know you're working within. You just make sure that the physician gets those orders in the computer or onto the chart and you sign them off. All right, so your antiplatelets, you have aspirin. Again, 325, chew, not swallowed, shaken, not stirred. Function, prevents platelet activation in relation to the inflammatory process. All right, so we have some ischemic injury going on, right? Something's happening. Anything that is an injury to the body, our body is naturally going to try to respond to it through the inflammatory process, correct? Here are your side effects. Increased risk of GI bleed, heartburn, nausea, and tinnitus. So you have persons who are on aspirin every day all the time, right? So sometimes your side effects become your teaching. If someone is taking aspirin, how do you need to tell them to monitor their chance of bleeding? Bruising. What else? How do they know they have a GI bleeding?
Tarry stool.
Black tarry stools. If it's not that way, can you have GI bleeding upwards? What does that look like? It could be bright red or it could be what? Coffee ground emesis, okay? And it does. It looks exactly like coffee grounds. What is tinnitus? Ringing of the ears. Flabbing, tickling. You can give these orally. Sometimes you can give them at during the heart attack. It just depends. Flabbing, depending on who your cardiologist is weight-based, but usually they'll give them 75. They take that once a day. Notice your side effects are the same as aspirin, but your function is a little different, okay? Heparin is an antiplatelet. What labs?
TPP.
PTT, PTINR, that's right. PTT goes with what? Heparin. Remember the 2 T's make a H. All right, so your PTT. This is given IV. You also given it how?
Sub-Q.
Sub-Q. In this case, for someone who's having an MI, sub-Q is not going to do us any good, all right? So we're going to put them on a heparin drip, and it is going to prevent the formation of new clots, and it reduces the risk of an MI in an unstable MI patient, okay? This does not destroy the clots. It prevents the formation of new clots. So your antiplatelets is pretty easy, right? Because they all have the same side effects as well.
What's the difference between prevents platelet aggregation and prevents platelet activation?
She just said it.
Oh, sorry.
When that inflammatory
Inflammatory
response
process.
is the activation.
Activation. Aggregation is the what?
The clot.
The huddling, the clotting, clumping, coming together. All right, you've given NT this one too, haven't you? And Actipril is what? Novanax. Usually it's given sub-Q. I have given it IV a couple of times. This one, who are you giving this one to? Unstable, okay? And this is going to reduce the risk of the rebound ischemic event. So that post-MI angina we were speaking of, this is where Lovenox comes into place. Here, your side effects, this is your quirky one. It has its own set of side effects. It's going to lower your blood pressure, increase your heart rate, and may even decrease your H&H. So again, we did those big old caveat of labs. Your CMP, we threw some coags in there along with our cardiac enzymes. Lovenox is weight-based in this sense. You can give it prophylactically, which is what we do on the units. So med-surg and tele, and they will get 40 or 30 every day prophylactically. In this case, someone who's having an active MI, it is weight-based. So that means you got to take those pounds and you have to convert them to kilograms and figure out your dose based off of that. Thrombolytics. This is your clot buster. This one will disintegrate the thrombi, causing vasal occlusion, okay? This is the one that destroys the clot, whereas heparin does what? Prevents the formation. Yes, ma'am.
That's what they just gave my mom with the TPA. Her port was clogged for her chemo.
Oh, chemo, they gave her TPA? They gave her a small dose.
Yeah, they gave her the TPA, and then after 30 minutes, she had blood return, and then they gave her heparin and flushed it.
Yep, so she got a small dose of TPA. TPA is top of the line, top gun medication, okay? I hate giving TPA because so many things can go wrong, even though one thing can go right. This person has to answer like 2 pages of a questionnaire before you can give this medication. Very strict parameters. One yes answer probably knocks them out of the box, okay? TPA is highly caustic. Depending on the pressure within that vessel, we can cause them to bleed out. Once you get TPA, in this sense, either for a stroke, which Professor Denson will teach you about, or for this, it's a long time before you can get it again, if you can ever get it again. So if we're giving TPA, this is something that they've gone through all the diagnostics, they figured it out, and the cardiologist wants to go this route, thinking it'll be safer than going in through with the cardiac cath. Make sense? Yes, ma'am.
Can paramedics give TPA?
No.
No. Even if they call the hospital, say, and they ask questions, they don't.
Oh, God, not twisting the back of that rig. Oh, no. No. This is, I mean, once you do this person is one-on-one for hours. So, you don't want to be slashing around in the back of an ambulance on TPA. All right, this is just the medications. This is everything that we talked about. I'll go back and review those. I don't know why that's there. All right. Core measures. Every hospital from here until eternity has core measures. Acute MI, core measures. These are the things that must be done for anybody who comes into your facility and they are diagnosed as a hospital. as a hospital, as a heart attack, all right? So aspirin at arrival. If they come in through the ED and they walk in or they're driven in, we have to make sure we give them an aspirin. There are pre-hospital protocols. If they have chest pain, they have their own little set of orders that they need to follow, and they must give them an aspirin. Aspirin is prescribed at discharge, okay? 3, don't worry about that. 4, smoking cessation advice for counseling. Doesn't mean they're gonna stop, but you need to tell them. Beta blocker prescribed at discharge, and yes, you do give them a beta blocker when they first get there. If they need thrombolysis, then we need to make sure there's that golden hour that we need to get them there. We talked about time to your PTCA, your cath. You need to get that done too. All these things are measured and data is sent, and that's going to drive how the federal government views your hospital, and also is going to drive how you are reimbursed. We beat congestive heart failure into the ground. I know you get it, I know you understand it. There are core measures for congestive heart failure as well, okay? This is where we were talking about your ejection fraction the very first day. This is where your left ventricular function assessment is going to be. So someone who has a very poor heart, they may be a candidate for infusions for congestive heart failure to keep that left ventricle functioning so they can be infused. Any questions, comments, or concerns? Yes, ma'am.
Our first exam covers cardiac and blood disorders only, right? Not respiratory
Right.
and oxygenation. That's the next test.
That's the next test.
And what's gonna happen Friday, I will, do the hematology, which are those disorders, the PowerPoints are up. Tuesday, now it says it's a test, but remember your tests are on Friday. Tuesday, I will finish up hematology and you will have your first concept living. What she's presented in the last 2 days, even though you have that big conglomerate PowerPoint, this is what you need to be zeroing on. Angina, CHF, acute MI, and the meds. Okay? And with me, I use a grid, which is your study guide. And I just,
I'm sorry.
All right, no other questions, no other comments, no other concerns. You got it down, Pat? All right.